Hi, everyone. My name is Dr. Scott O'Neill. I'm one of the orthopedic sports surgeons, and I operate out of the OrthoCarolina office in Ballantyne. Welcome to this month's webinar. I'll be talking about shoulder dislocation. A replay of this video will be available on our Facebook and LinkedIn, as well as our YouTube pages. During the webinar, if you have questions, please feel free to leave them in the comments section. We'll organize those and get to them at the end of the presentation, and we'll try and get through as many as we can in the limited amount of time we have. But without further ado, I figure we'll go ahead and get started. So a little bit about my background. I'm originally from Southern California. I went to college down in sunny UC San Diego. I then spent some time up at University of Michigan, where I went to medical school. Based on my time in San Diego, and then going to Michigan, I needed to get some more sun, so I went down to the University of Miami, Jackson Memorial Hospital, and I did residency there for 5 years. At the completion of my residency, I came home to OrthoCarolina and did my sports medicine and shoulder and elbow fellowship, and then I've been down in the Ballantyne office since 2011. So what's my plan for this evening? I figure we would talk a little bit about the anatomy of the shoulder, just to give you guys a little bit of a background. We'll talk a little bit about surgery versus no surgery and why we may choose one or the other. We'll talk about timing of surgery. We'll talk about surgery a little bit in detail and the different options that are available when you have a shoulder dislocation. We'll talk a little bit about the rehab, and then we'll fill in some gaps with something called multi-directional instability, as well as dislocation over the age of 40. And then obviously we'll have some time for some questions at the end. So the shoulder joint is inherently unstable, and this is unfortunately by design. So when you look at the shoulder joint, this is an x-ray, one looking at the front of the shoulder and then one looking with the shoulder on its side. And when you look here, you can see the ball, golf ball sitting on the golf tee is the analogy that I use. And when you look at it schematically, the reason why it's unstable is because the humeral head or the ball of the shoulder is so much bigger than the golf tee. In measurements, it's 2 to sometimes 4 times bigger than the glenoid or the golf tee. This allows for a large arc of motion where we can be very mobile, but unfortunately, that arc of motion and lack of congruency leads to inherent instability. So the analogy that my mentor, Dr. Connor, brought up was, it's like a seal trying to balance a ball on its nose. So the stability of the shoulder is basically through two different stabilizers. One is the static stabilizers, and one is the dynamic stabilizers. We're going to go over the static ones first. So when you look at the static stabilizers, the first one is basically just the ball and the socket. The actual contact does confer stability. The glenoid labrum, which circles the socket, and we'll talk about that in a minute. The joint capsule, and then the ligaments. And the ligaments are outlined here: the superior glenohumeral ligament, the middle glenohumeral ligament, and then something that makes up what we sort of refer to as the hammock, the anterior band, the axillary pouch, and the posterior band of the IGHL. So talking a little bit more about the labrum, it basically, if you look at the labrum, it basically serves to deepen the socket. And it helps to increase the contact area, and that confers stability. But even more importantly, it serves as the attachment site for all those ligaments I just talked about. So the other function it does too is it actually acts as a bumper. So when the shoulder is pressed up against the glenoid, you can see how the glenoid of the socket, you can see how that labrum kind of flattens out in that top right picture. And then that helps to deepen the socket and also acts as a bumper that you can see below. When we talk about the dynamic stabilizers, that's going to be your rotator cuff. So the 4 muscles that make up the rotator cuff are the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. The biceps tendon also has a function as a secondary stabilizer, really important in throwing athletes. But when you look at the rotator cuff, it pulls the ball into the socket and acts as the dynamic stabilizer to help keep the shoulder located. So what happens? Well, you have this x-ray right here. A person was out messing around, fell, and dislocated his shoulder. They show up in the emergency room or urgent care, and they have an x-ray like this. We get them back in the socket. It looks something like this afterwards. And so what is next? So one of the things to consider is, do you actually need surgery? And so it kind of depends on where you are and what point of your life you're at, your activity level. Are you going back to playing sports? So when you look at non-operative treatment versus operative treatment, non-operative treatment has a really high failure rate, especially in the younger population. These were some of the guys that started figuring this out very early on. This goes all the way back to the 80s and 90s, and they were just basically looking at how can we treat this without surgery, but then they started noticing that this was a really high failure rate, somewhere between 50 and 90%. And when you look at more longitudinal studies, where they looked at a group of patients basically under 40 years old, you can see the curve at the very bottom, or the line at the bottom in green. Those are your 16 to 20-year-olds, and they have the highest dislocation rate without operative treatment or with non-operative treatment. So when we think about timing of surgery, when to do surgery, the number of dislocations does predict bone loss. And the problem with bone loss is that the more bone you lose, the more unstable your shoulder gets. So with each dislocation, with each dislocation, there's a 95% risk that you're going to lose more and more bone. And that makes things harder. So the way we sort of think about it is bone loss is bad. You lose more bone, you become more unstable. This actually makes our surgeries much more complicated when we have to address the instability. And on the back end, even more importantly, it increases the risk of surgical failure. The second thing that happens is the more times you dislocate, the more times you beat up your joint. And so you tend to start to get cartilage injuries. And that cartilage is the smooth, slippery surface that we all have in our joints that allows us to have a painless arc of motion. Once you start getting these dislocations, the cartilage gets more and more beat up, and then you have increased risk of potential arthritis. So more dislocations equals more cartilage injury equals increased risk of post-traumatic arthritis. And so you take a beautiful x-ray like the one that you see on your screen with a smooth ball and a smooth socket. They have a bunch of dislocations, and down the road, they end up developing post-traumatic arthritis, where they basically lose their joint surface. You have a large bone spur, and the shoulder doesn't work very well at that point. So why do we talk about surgery? It's because it works. In the vast majority of cases, 85% success rate in reducing the risk of recurrent dislocation versus putting it up against physical therapy for that first-time dislocation. Remember, some of those earlier studies showed a 90% chance of redislocation without surgery. So one of the biggest questions I get asked is, well, when do we need to do the surgery? Well, fortunately, if it's a fairly simple dislocation with a simple set of problems, the timing of surgery is not an emergency. But we also want to prevent recurrent dislocations because, as I talked about, more dislocations leads to more bone loss, which leads to more cartilage injury, which then leads to arthritis. So my sort of thought process is we should do it sooner rather than later, but it's not an emergency. A lot of times we'll send people to therapy just for a little bit, get the joint tuned up before surgery so that it's not too stiff. But we do have some special considerations, especially when we're dealing with our athletes. One of the considerations is start of season dislocation. We just started football season, and little Johnny's shoulder popped out. What are we going to do? Can he play through it? Do we need to fix him right away? And that's a discussion that we have to have, with the parents and the athlete, and try and figure out what's best for them. Another consideration that actually factors in quite a lot is this their last year of eligibility? Is this the last time that they're going to get a chance to play football or lacrosse or rugby or whatever it is? And that factors in as well. As long as everybody's on board and understands the risks, sometimes this is something that we can play through. The one caveat would be is that when you dislocate your shoulder, if you do have a bony injury at the time of dislocation, those are ones that should be treated sooner rather than later. And unfortunately, a lot of times that would limit their ability to try and finish the season. So how do we fix them? So most of them are fixed arthroscopically. That's the minimally invasive. And basically, it's just some poke holes around the shoulder, usually 3 or 4, and that's for the camera and the instruments. And we use that to get into your shoulder joint and fix what's damaged. This is a picture of a person laying on their side. The ball is towards the top of the screen. The socket is towards the bottom, and they're laying on their side. And we're looking basically from back to front. And in the very front of the shoulder, you can see the tearing of the labrum from the rim of that glenoid, or the golf tee. You can see it right there. So how do we fix it? So that previous picture where we got this tear, what we're going to do is we're actually going to make it a little bit worse. And the way we do that is we elevate it up and then we roughen up the bone to make it bleed. And that's what you see on the picture on the left. And the idea of doing that is not to take away the bone, it's just to roughen it up to create a bony surface to allow healing. And then once we do that, then we start putting in anchors. And anchors are basically things that we drive into the socket on the edge of the bone. They have suture attached to it. In this case, these are some of the knotless suture anchors, and we basically tie that down, and that restores the bumper. And one thing that you can see that's pretty dramatic, if you look at the picture on the left, the socket's on the right, but the top left corner is sort of the middle of the ball, and you can see how far off the screen it is. Once you restore and fix the capsule and get everything back, if you look at the picture on the right, you can see how the ball is now sitting basically centered on the socket. There are other surgical options. Excuse me. We in the past used to do open stabilization, and there's also surgeries for when you start to lose bone. The open label repair, that was basically classically how we used to do it before we had arthroscopy, and it still does serve a place for more complex injuries and for certain considerations. I still do that on a not too infrequent basis, but it's under special circumstances. Rehab is similar, but with the open surgery comes complications, or potential complications, I should say. Stiffness. You do have to violate the rotator cuff, the muscle in the front, specifically called the subscapularis when you do this. And sometimes that can lead to some rotator cuff dysfunction. And also because it's an open procedure, there is an increased risk of infection. So what do we do if the person's lost bone? So we gotta replace the bone. And so we call it bony augmentation. And then the reason why we have to augment with the bone is that when you lose it, it compromises stability, or the dish or the golf tee that I talked about previously. The classic surgery for this is something called the Latarjet, developed by a guy from France. And basically what we do is we take the tip of a coracoid, which is a bone in the front of the shoulder. It's a little knobby thing that you can feel in the front of your shoulder. We basically saw that off and use that along with some tendons and tissue that's attached to restore the socket. It also helps us to create a sling effect, which helps to stabilize the shoulder. It's a very complex surgery. There is a much, much higher risk of complications, but it's very popular in Europe. And if you're a young athlete in Europe and you dislocate your shoulder, chances are that's the first surgery that they go to. But there are some drawbacks to it, which I can expand upon later. This is just a little animation of what it is, and you can see where they took the bony piece and transferred it to the front of the shoulder to make up where the bone loss is. A couple of screws to hold everything together. And then this is the follow-up x-ray that it looks like after we do that transfer. What about the rehab? So rehab is pretty straightforward. Usually it's a sling for about 6 weeks. Early physical therapy is focused on keeping some motion, but allowing that repair to heal. And remember, on one of those earlier pictures, I talked about actually we kind of open everything up in order to fix it. And so if you try and move too fast, too soon, things don't get a chance to heal. And so a little stiffness early on is okay. Not overly stiff, but a little bit of stiffness is good. Once you pass the 6-week mark, we're getting you out of the sling. We're trying to regain some motion, a little bit of strengthening. As you cross over the 3-month mark, months 4 and 5, really focusing on getting you strong again. And then month 6 is sport-specific training, with hopefully getting you back to sport after you finish month 6. So we talked about traumatic instability, where you basically fall down, big hit on the football field. But what about people that are born a little bit more flexible or loose? I refer to them as loosey-goosey. These are people that have hyperextension in their elbows, hyperextension in their knees, joints are loose. They can bend their fingers back and touch their wrists. And so when you see that happen in the shoulder, it's something we refer to as multi-directional instability. And so what this is some inherent joint laxity. And this is basically related to the capsule, the ligaments, all the static stabilizers in the shoulder. It's much more common in females. And we can also see it in athletes that have repetitive microtrauma. So swimmers and gymnasts are susceptible to this. Usually we see it in both shoulders. Their biggest complaint is their shoulders just hurt. Some of them will have that sensation of a dead arm where it feels like their arm is asleep, and that's because the ball is somewhat sliding out of socket and pressing on nerves that just cause that sensation of your arm being asleep. Some of them will actually feel like their shoulders dancing around, and they're like, yeah, I can feel it pop in and out. But the key to that is that it's not painful for most people. It's disturbing, but not painful. And so the hallmark sign of this is you take somebody and you basically pull on their shoulder, and you can actually see in this picture, this lady's shoulder is dislocated. It's dislocated inferiorly as the doctor pulls it down, and you can see that little divot in the front of her shoulder. That's what we call a sulcus sign. But the key to this is if you look at her face, even though she's dislocated, it's not bothering her one bit. And that's classic for this particular issue. So what's the treatment for it? So you have somebody that comes into our office who's loosey-goosey. We send them to rehab. And if that doesn't work, we send them back to rehab. And if that doesn't work, we send them back to rehab. In very rare circumstances, we will talk about doing surgery. It's a big conversation because they were built, again, loosey-goosey, so these things have a tendency to stretch out. So in instances where we just can't get it right with the rehab and everybody has bought into it, there is some surgery for it. But again, it's something we can talk about during the comments if people are interested. What's really important for people to understand that have this condition is that once you understand the rehab program, it needs to be a lifelong sort of commitment. And that's because you need to keep those dynamic stabilizers tuned up to keep the shoulder in the socket. And so basically I tell everybody it needs to be sort of incorporated into a weekly routine. It's not meant to be overwhelming, but a couple times a week, you got to do your shoulder program, for 20 minutes a day to keep your shoulders strong. And that's going back to that picture where I was showing the dynamic stabilizers, keeping that ball socked into the socket. So we got our athletes that have the traumatic dislocation. We have the people who are loosey-goosey, but what about somebody who's over the age of 40? I'm in that club, so this hits home. So most of these people will not need surgery for stability. But unfortunately, with the dislocation in somebody who's over the age of 40, you can tear your rotator cuff. So even though you may not need surgery, we're obligated to get the MRI to make sure that we don't have damage to that rotator cuff. If the rotator cuff is not torn, then a lot of times we can get through this without surgery, just need some rehab, even if you do have a labral tear. We usually treat this with a period of rest. This allows a little bit of stiffness to set in, helps to stabilize the shoulder, let things scar in, and then we get you in to do some therapy to restore motion, function, and most importantly, strength. So what about somebody who's a little bit older than that 40-year-old? So what I'm sort of getting at is the people who are kind of 60 and over. This is much more likely to result in a tearing of the rotator cuff, but also a much, much greater chance of fracture, especially females. When you have the dislocation in this patient population, surgery is more often needed, and a lot of times it leads to a shoulder replacement, and that's especially in that fracture category. So you take somebody who has a dislocation and fractures their shoulder, and the bones are in a bunch of pieces. We typically won't put these back together, but instead we will just move forward with what's called a reverse shoulder replacement. It has better outcomes. So that was a lot of stuff I just covered. It's a pretty broad overview of a very complex topic. I hope you guys enjoyed it. I hope you found it at least a little bit insightful. We do have some time now, so if anybody has some questions, we can move forward and get to those. Let me click here. I did it. Perfect. So the question is, are there any new treatments for shoulder instability due to previous frozen shoulder trying to freeze again? So recurrence of frozen shoulder is actually pretty rare. When we look at a frozen shoulder, it's stiff, so it's not unstable, though it may feel unstable because you feel some popping and clicking, and it may feel like it's getting out of joint. It's typically not, it's not unstable. So for that, I don't really think there's any new treatments. The mainstay of treatment for somebody who has frozen shoulder is to get into therapy and get that shoulder stretched out and then rebalance the rotator cuff. How does orthopedic research impact your practice with shoulder dislocation and instability? So research is super important, especially recently. I shouldn't say recently, probably over the last few years. We're always trying to do our surgeries better, trying to make it so that people don't have recurrence. And again, a lot of the stuff we do is arthroscopic, and a lot of the techniques that we have are because of the research that drives us and points us in the right direction. There are little nuances to the surgery that can be added on to help stabilize the shoulder and actually reduce the risk of recurrence. And that's where research really does help. Can I get this surgery in an ambulatory surgery center, or do I have to go to the hospital? So I would say probably 95%, maybe 99% can get this done in an ambulatory surgery center. The things that would drive you away from the ambulatory surgery centers if you had significant medical comorbidities that would put you at risk for having surgery, such as heart disease, lung disease, something where you might have to be admitted after the procedure, and that would be probably the only reason that you'd have to go to a hospital. Do you have any tips on weightlifting with a bad shoulder? So yes, depending on what that problem is with your bad shoulder. If it's an arthritic shoulder, it's a kind of a complete reset of what you're doing in the gym to make sure you're not breaking down that shoulder any further. If you've got a partial rotator cuff tear, again, modifying some of the stuff that you're doing, that's where actually working with a sports therapist can actually help. And I'll send patients all the time to get a basic shoulder program, and then also, most importantly, help them with their workout program moving forward. Are there exercises to improve movement and use of torn tendons or surgery required? Once that tendon is torn off of the bone, it's not going to heal back. There are some exercises that you can do where, let's say we have an older person who's got a rotator cuff tear, but doesn't want to do surgery, still functioning well, just having some pain, and we just got to get the shoulder rebalanced. There are some exercises that you can do, and again, that's where the therapist helps to try and rebalance the shoulder to take over where those tendons have been torn off to help get them some better function and relieve the pain. Can surgical intervention be effective for someone with a connective tissue disorder? In my case, Ehlers-Danlos. Okay. If I have frequent dislocations, but the rotator cuff and labrum, I'm assuming intact. So that's a tough one. The mainstay of treatment for somebody who has Ehlers-Danlos, who's having shoulder instability, is rehab and utilizing the dynamic stabilizers. And the reason why is, unfortunately, mom and dad built you with collagen that doesn't like to stay stiff. And so we can go in and do the best arthroscopic or open surgery in the world and get everything back to where it needs to be, tighten you up. And over time, because the collagen in your shoulder is inherently more likely to stretch out, you just become unstable again. There's guys that have attempted to add tissue and do these really complex surgical interventions, and they're prone to complications. They're prone to infection. They're prone to all sorts of things, and the outcomes have not been good. So I would recommend to somebody who unfortunately has this Ehlers-Danlos would be, you rehab your shoulder like crazy, balance that rotator cuff, and hopefully that'll keep the shoulder stable. How can I manage pain until shoulder surgery is performed? So it's a balance, right? So if you don't have a fracture, it really is trying to maintain motion, a little bit of gentle stretching. That's sometimes where we'll send you to do what's called prehab, work with the therapist, not for a bunch of visits, just a couple of visits, give you a little program to work on. And then it really is over-the-counter medications, Tylenol, anti-inflammatories. We typically do not prescribe narcotic pain medication prior to any surgery if we can help it. Because it makes controlling your pain after surgery extremely difficult. How do you know if you have a pulled muscle or something more serious? I think you just need to have an evaluation by one of us. That would probably be your best bet. How long should I continue doing the PT exercises to strengthen my injured shoulder? When will I know it's time to stop the PT? It really kind of depends on what's wrong with your shoulder. Like we were talking about with the people who are loosey-goosey, they have to continue doing the exercises sort of indefinitely, not obviously as frequently or as intensely as they were to try and get their shoulder stabilized. But it's something that they would need to continue to do lifelong. I'll send somebody they'll injure themselves at the gym, and especially the 40 and 50 something year old males who come in with some shoulder issues, and I tell them to keep up with their shoulder program while they return to the gym. Again, they don't have to do it as frequently, but as frequently, but they still need to keep it up, and it's something that they can just add into their normal routine. But at that point, they're doing everything on their own. Is there a way to prevent another shoulder dislocation? So that would be something it depends on your mechanism of injury, how much damage was there, what surgery you had, and then avoidance of some of those high-risk activities. Those are probably your best bets. The other thing is to make sure you rehab appropriately. Don't do things too quickly during your rehab, and hopefully that will get it to stay in the joint. I have limited mobility in my right upper arm. Could it be shoulder related? Sure. It could also be related to your neck. It could be related to your shoulder blade. All those sorts of things factor in. But that's something where getting in and seeing one of us can help you kind of work through it to figure out exactly what's causing your issue. My shoulder hurts every night when I go to bed, but it feels a little better with a heating pad on it. Does this sound like arthritis or something else? It could be a lot of things. Arthritis tends to hurt at the end of the day. The knees hurt a little bit more, the shoulders hurt a little bit more, hips hurt a little bit more after the pounding that they take throughout the day. Heat sometimes is something that can help with arthritis, especially loosening it up. The other thing it could be a frozen shoulder. Sometimes with a frozen shoulder, adhesive capsulitis, putting a heating pad on it can help loosen it up and provide you with some relief. I am a swimmer. How can I avoid repetitive motion injury to my shoulder during freestyle? Don't do freestyle. So I don't have a great answer for that one. Unfortunately, that's one of the butterfly is a tough one too. If you're a swimmer competitively, unfortunately, you're competing and you're swimming and you're training so that you can compete. If you're a swimmer to stay in shape, I tell people it's all about moderation. Swim one day, do some dry land work the next, and then swim the next day. And that way you're doing something different. What is the cause or / treatment for painful shoulder popping? So that could be due to a whole host of things. That can be due to a chronic labral tear, something degenerative in nature, not necessarily from a dislocation. It could be from bursitis in your shoulder, little fluid shifts kind of moving back and forth. It could be from an unstable biceps in the front of your shoulder kind of snapping back and forth. So unfortunately, you got to identify what it is first and then design a treatment plan around it. How do you treat frozen shoulder? So I end up seeing this a lot in my clinic. It's one of the most common diagnoses that we deal with. It's the mainstay of treatment is non-operative. I tell everybody the mantra is you have to stretch every day. You have to stretch several times a day, but not for hours at a time. The idea is you stretch this thing multiple times throughout the day for short bursts of time. And as you stretch it out, you get little gains throughout the day. If you get up first thing in the morning and stretch it for an hour, it tends to get really irritable, and then you guard it all day. And unfortunately, you don't get any benefit from it. We add in some anti-inflammatories, and for some people, we'll treat them with a steroid injection if they really need it. I am a 50-year-old former racket and tennis player. I have that dead arm feeling from time to time, and it feels like it wants to pop out randomly when doing something. Any tips? I would come in and see somebody. Got to check and figure out what's going on with you. Make sure you don't have some arthritis in the shoulder. Overhead athletes, such as tennis players, baseball players, they tend to beat up their shoulders a little bit, and want to make sure that you don't have something else that's a little bit more sinister kicking around. It may be just as simple as rehab and getting you stretched out and getting you in for what I would call a 50,000 mile tune-up. and then get you back on the courts. Or it may be something that we need to chase a little bit further, MRI, and talk to you about doing something. I had impingement of my right shoulder. Therapy worked great, but now it's starting to be the same. Is this a case where I need to be constantly doing the exercise, or could it be something else? So the answer is yes and yes. This is one of those situations where you probably needed to keep up on your shoulder program. Again, not as intensely as you were doing to get it to settle down. But it could be something else. A lot of people that have impingement will have a little partial rotator cuff tear, and sometimes that progresses. If pain is getting worse, having more pain at night, that's something that should probably be rechecked. And a lot of times, if people had improvement with therapy, but the pain comes back, we'll move forward with an MRI to better look at your shoulder. I had rotator cuff surgery years ago, but the pain has come back. Does age have anything to do with this, or would therapy be helpful? So age has everything to do with everything hurting, right? I just woke up out of bed and I injured myself while sleeping, right? That's the classic story. So yes, age definitely factors in. But I don't think you necessarily have to be overly nervous. Part of it is, again, getting in and seeing somebody. Some people after rotator cuff surgery can develop some arthritis down the road. Some people can re-tear their rotator cuff. Probably needs an exam, a set of x-rays, and then determine, would therapy be helpful, or is it something that you need to move forward with imaging, such as like an MRI. Can you address shoulder impingement? Yeah. So shoulder impingement is basically where the rotator cuff gets pinched, or the simplest way to think about it is the way that your shoulder works. When you bring your shoulder up into this position, you can pinch your rotator cuff between the bone coming off of your shoulder, called the acromion. It can lead to irritation of the rotator cuff, can cause inflammation in the subacromial bursa. The mainstay of treatment is to reduce the inflammation with anti-inflammatories, and then work on a rotator cuff program to help rebalance the shoulder, because as the rotator cuff gets inflamed and irritated, it doesn't work very well, and it tends to lead to more shoulder dysfunction. When you're at the gym, you want to stay away from those exercises, specifically coming out. That a lot of guys will do those lateral raises, and all they're doing is they're just grinding their rotator cuff. It's not a great exercise. I tell everybody, don't ever do those. What are some common symptoms for frozen shoulder? Well, the hallmark of frozen shoulder is the shoulder's frozen, so it doesn't move. So you can check at home and basically look at the difference between motion from the affected side and the unaffected side. And so if you're starting to lose motion, that's probably a frozen shoulder. Do labrum and rotator cuff injuries require different treatments? Yes, totally different. Two different spectrums. Labrum has to do with stability, and rotator cuff has to do with strength and function of the joint. Can shoulder instability lead to arthritis and other complications later? Yep. Remember those pictures I showed where you took the nice looking ball and socket joint that was smooth, and over time it breaks down and leads to the arthritis. What are the common causes of a rotator cuff tear? Well, number one is age. The analogy I use is when you were a kid and you were given a new pair of pants from your parents, and you immediately ran outside and tripped and fell on the concrete and scuffed the jeans. That's what happens through life. And so what happens is our rotator cuffs take a bunch of scuffs, and over time, our capacity to heal those gets less and less and less. And then that leads to rotator cuff tears down the road. Things that make it worse, smoking. People who are smokers tend to have more rotator cuff tears. Trauma, falling out of a tree, falling down some stairs, having a traction injury, you can get a traumatic tear. But most of it is just repetitive use and an age thing. What at-home exercises can I do to rehab my dislocated shoulder? That's a pretty complicated, in-depth sort of question. That's something where we would have you work with the therapist to basically set up your home program. That's a little bit more than we have time to go into. What are your thoughts on heavy lean protein load pre and post-op? So I think as long as you're eating a sensible diet, I don't think you have to overload on protein on either side of it. Just a standard healthy diet is basically what you need. Can my neck pain near my shoulder be related to a shoulder injury? Absolutely. What can happen is as your shoulder's bothering you, you tend to guard the shoulder and you tend to hold the shoulder up. This is obviously, I'm exaggerating, but by doing that, it tends to irritate the muscles around the neck, causing some myofascial pain around the neck, and can cause some spasm and some other issues with your neck. What are the typical symptoms of a labral tear versus rotator cuff tear? So typically with a rotator cuff tear, you have pain and weakness. Labral tear is probably more pain, but can cause some inhibition in the shoulder and lead to some weakness. But again, that's where a good physical exam by your orthopedic surgeon can help you kind of work through that. What activities should I avoid during shoulder recovery? Trying to do things too fast is basically the deal that I tell all patients. It's a tortoise and hare analogy. You want to be the tortoise, you don't want to be the hare. What do you think of hanging from a pull-up bar to treat shoulder impingement? I like that more for frozen shoulder. Once they start to get their motion back, I think you can hang from a pull-up bar to help with restoring the forward elevation of the shoulder. I'm not sure it's going to help with shoulder impingement. What causes the popping and clicking that occurs in the shoulder? Are trigger points as well as a common thing in your scapula between the shoulder blades? What causes these? So I already talked about the popping and clicking from the other question. Trigger points, a lot of times if you're having a lot of discomfort between your shoulder blades, that a lot of times is caused by neck issues, cervical radiculitis, where you're pinching a nerve in your neck. That tends to cause the pain radiating between the shoulder blades. I have shoulder pain that is worse at night. Any reasons why? So people that have rotator cuff tears tend to have a little bit more pain at night. And my personal thought is that as people start to relax and drift off into REM sleep, everything kind of relaxes and it kind of tugs on the shoulder, and where they still have some connected fibers in the rotator cuff, it tends to hurt a little bit more. But that's a common complaint for somebody that has a rotator cuff injury. All right. I guess we hit our time limit, so thank you all for attending. Just as a reminder, the replays will be on our Facebook, LinkedIn, and the YouTube page. Thank you very much. Have a good night, and thank you for attending.